But there's some other parts may not do it. So anterior approach to the hip, a slight modification to show what all can be achieved through this anterior approach. So I'm showing you the pubic tubercle with a cadaver dissection. Pubic tubercle, ASIS. Somewhere down below is the hip joint right in the middle there. That's a reasonable incision to make right there. Make the incision. You can find the lateral subcutaneous if you want it. Cadaver dissection, I found it and I tagged it. Right? Put a little suture around it. Then you decide if you want to go medial lateral sartorius. It doesn't matter. Sartorius is such a long muscle, you can pull it either way with no decrease in exposure. So sartorius doesn't matter. You don't need to take it down. Just go medial lateral sartorius, depending on how medial, if you want to go medial into the sternum or the pelvis or lateral to the femoral neck. The sartorius either way is fine. Deep down, you have your rectus tendon. I don't think you need to cut the rectus. Go medial to the rectus. If you need to see the labrum, acetabular wall, and things like that, go lateral to the rectus. If it's more of a neck you need to see, or you can work on both sides of the rectus without taking it down and do a lot of work underneath the rectus. So it's no big deal if you cut the rectus, but you can do all these things without cutting the rectus. And there's some evidence that rectus sparing approach has quicker recovery of their knee and hip strength. I don't believe in it completely, but right now most of us are trying to preserve the rectus, even with pretty much any surgery. Right? So you have your rectus pulled out. Right next to the rectus is the iliocapsularis and then the iliopsoas muscle. And the femoral nerve is on the other side, very well protected. So if you pull the iliopsoas off, medial to the rectus, way out like we did for the gans osteotomy, not as much dissection. Let's see what all we can see. You can go to the SI joint with that incision, right? All the way to the SI joint. You can drain SI abscess or infection just with this approach, right? There's not a whole lot to do in an inner table, but one of the delegates, I don't remember who, said that he actually goes from the inside to curate out medial acetabular lesions. You can probably get to it, but it's an indirect approach, right? And you can fix anterior wall fracture of the acetabular, right? You have enough exposure to put the piece back and screw it, right? Then you see the labrum. You can do everything I said I can do arthroscopically with this approach. Take the labrum down, remove the limb behind it, throw the labrum back. The only thing I'll caution you is be very careful in placing your anchor because you're not seeing inside the joint. When I put my anchors, I want to see if I'm doing any damage to the arterial cartilage or my drill is penetrating the arterial cartilage. You won't see that unless you distract and look inside. There are modifications to this. You can distract with a bone hook and put a dental mirror, several dental mirrors to see inside like what I see arthroscopically. So you don't need to learn arthroscopy to do all these things. A small incision like this, labral work, you can do the rim trimming, right? And then, yeah, labrum, right? You can take it, sew it, the head neck. You can start your osteoplasty there with an osteotome. And if you're going to go further lateral, you can go down on the neck, way down. Flex the hip up a little bit, rectus will relax, you go down, or swing the rectus over medially and work lateral to the rectus. And you can do all these surgeries through anterior approach. So, a nice approach to do a lot of things in the hip. Again, shows you anatomy. The femoral nerve is well protected with the iliopsoas. So when you're doing your PAO exposure, you're pulling the iliopsoas out medially and you're protecting everything else. The branch of rectus will be somewhere down here, and that's what gets damaged if you go extensively way down. But we're not going to go way down. We're going to start at the hip joint. So this first branch is very safe down here for the rectus. So medial to rectus is okay. Showing an old case where I did a femoral neck fracture. I open reduce all my femoral neck fractures at all age. I open reduce them, look at it, decompress the hematoma. So this thing is inside the pelvis. This is above the neck, below the neck. I put a joystick in the head to control my head. I use fracture table to control the distal fragment, adjust my alignment quite well, put a clamp if I have to compress the fracture, and then fix it with percutaneous screws from the lateral side. It's a nice small approach for all that. That was that case. I happened to put a retrograde nail and then go in between, luckily got in between. Some screws are not parallel because I would maneuver around screws. That's when I was doing adult trauma in my earlier life. So that's the anterior approach. Any questions on that?
On the rate, there were no increase in AVN or anything like that.
With this approach?